Dear doctors, if you are preparing for EDIC Part 1, you are at right place. Today in this video, I am going to discuss MCQs related to nephrology section of EDIC Part 1.
Question 1. A 65-year-old man with septic shock on norepinephrine develops oliguria and rising creatinine. Urine sodium is 55 millimole per liter, urine osmolality is 250 milliosmol per kg, and fractional excretion of sodium is 3%. A renal ultrasound is normal. The intensivist considers starting renal replacement therapy. Which of the following is the most appropriate immediate step? Initiate CRT immediately for oliguria. B. Administer high-dose loop diuretics to improve urine output. C. Optimize intravascular volume status and reassess renal function. D. Insert intra-aortic balloon pump to improve renal perfusion. Perform renal biopsy to rule out intrinsic renal disease. Correct answer is C. Optimize intravascular volume status and reassess renal function. Explanation. The patient has septic AKI with high FeNO and low urine osmolality suggesting intrinsic renal injury, likely ATN. However, the immediate step is to ensure optimization of hemodynamics consisting of volume status, perfusion pressure, and sepsis control before RRT is initiated. RRT is indicated for refractory hyperkalemia, metabolic acidosis, severe fluid overload, or uremic complications, not just oliguria. Loop diuretics may help fluid balance but do not improve outcomes. IABP is not indicated here. Biopsy is not appropriate acutely in septic AKI. Question 2. Which statement regarding renal autoregulation in critically ill patients is most accurate? Renal blood flow is autoregulated between mean arterial pressure 40 to 160 millimeters of mercury in healthy individuals. B. Sympathetic activation leads to afferent arteriolar constriction, decreasing GFR. C. Angiotensin II preferentially constricts the afferent arteriole to maintain filtration fraction. Prostaglandins primarily dilate the efferent arteriole to preserve renal perfusion. In sepsis, autoregulation is often impaired, making renal blood flow more dependent on systemic pressure. Correct answer is E. In sepsis, autoregulation is often impaired, making renal blood flow more dependent on systemic pressure. Explanation. In healthy individuals, autoregulation maintains renal blood flow between MAP 80 to 180 millimeters of mercury. Sympathetic activation causes afferent and efferent arteriolar constriction, often lowering GFR but preserving perfusion. Angiotensin II preferentially constricts the efferent arteriole, not afferent, maintaining filtration fraction. Prostaglandins dilate the afferent arteriole, not efferent, preserving perfusion under stress. In sepsis and shock, autoregulation fails, making renal perfusion highly pressure-dependent. Question 3. A 72-year-old man with multi-organ failure is on continuous renal replacement therapy using continuous veno-venous hemodiafiltration. His prescribed effluent dose is 30 milliliters per kilogram per hour. Over the past 24 hours, frequent filter clotting reduced effective effluent delivery to 20 milliliters per kilogram per hour. His potassium and urea remain high. Which of the following is the best next strategy? Increase dialysate potassium to avoid rapid shifts. B. Reduce prescribed dose to 25 milliliters per kilogram per hour to decrease filter clotting. C. Switch to intermittent hemodialysis for higher clearance. D. Optimize anticoagulation and filter lifespan to achieve the prescribed dose. Increase ultrafiltration rate to enhance solute clearance. Correct answer is D. Optimize anticoagulation and filter lifespan to achieve the prescribed dose. Explanation. Continuous renal replacement therapy efficacy depends on delivered dose, not just prescribed dose. Target dose is 20 to 25 milliliter per kg per hour delivered. Inadequate clearance here is due to filter clotting. Optimizing anticoagulation, regional citrate or heparin, is the best strategy. Reducing dose may further worsen clearance. Intermittent hemodialysis may be considered if continuous renal replacement therapy repeatedly fails, But first line is troubleshooting continuous therapy. Increasing ultrafiltration affects fluid, not solute clearance directly. Question 4. A 48-year-old man with septic shock is mechanically ventilated. He has been on vasopressors and is receiving RT. His current ventilator settings are: mode, volume control, tidal volume, 6 milliliters per kilogram, respiratory rate, 22 per minute, FiO2, 0.6, PEEP 10 centimeter of water, arterial blood gas, pH, 7.29, partial pressure of CO2, 50 millimeters of mercury, bicarbonate, 20 millimoles per liter, sodium, 140 millimoles per liter, chloride, 108 millimoles per liter, potassium, 4.2 millimoles per liter, lactate, 7 millimoles per liter. Which of the following best describes his acid-base disorder? Mixed high anion gap and normal anion gap metabolic acidosis with respiratory acidosis. B. High anion gap metabolic acidosis with appropriate respiratory compensation. C. Normal anion gap metabolic acidosis with respiratory alkalosis. D. High anion gap metabolic acidosis and metabolic alkalosis, triple disorder. Metabolic acidosis with respiratory alkalosis due to ventilator settings. Correct answer is A. Mixed high anion gap and normal anion gap metabolic acidosis with respiratory acidosis. Stepwise explanation. Identify primary disturbance. pH equals 7.29, acidemia. Bicarbonate equals 20, low, metabolic acidosis present. Partial pressure of CO2 equals 50, high, respiratory acidosis present. So, mixed metabolic plus respiratory disorder. Calculate anion gap. It is 12. It is normal. But lactate equals 7 millimoles per liter, there should be a high anion gap. This suggests a combined disturbance. High anion gap metabolic acidosis, lactic acidosis. Normal anion gap, hyperchloremic, metabolic acidosis, likely due to CRRT fluid or resuscitation with chloride-rich fluids. Check respiratory compensation with Winter's formula. Expected partial pressure of CO2 equals 36 to 40. Actual partial pressure of CO2 equals 50, higher than expected. Superimposed respiratory acidosis, likely from ventilator settings or hypoventilation. Question 5. A 54-year-old woman is admitted to the ICU after elective neurosurgery for pituitary adenoma. On post-op day 2, she becomes acutely confused and has a generalized tonic-clonic seizure. Labs. Serum sodium, 110 millimoles per liter, measured 2 hours ago, 114 millimoles per liter. Serum potassium, 3 millimoles per liter. Serum osmolality, 235 milliosmol per kg. Urine sodium, 70 millimoles per liter. Urine osmolality, 600 milliosmol per kg. She is currently intubated for airway protection. Which of the following is the most appropriate immediate management strategy? Start 3% hypertonic saline infusion at 30 milliliters per hour, targeting sodium rise of 8 to 10 millimoles per liter in 24 hours. B. Give 150 milliliters 3% hypertonic saline bolus over 10 minutes, repeat if needed, while monitoring sodium every 2 hours. C. Begin fluid restriction and oral urea to correct syndrome of inappropriate antidiuretic hormone-related hyponatremia. D. Initiate continuous renal replacement therapy with high-sodium dialysate to gradually correct sodium. Administer vasopressin receptor antagonist, tolvaptan, after seizure control. Correct answer is B. Give 150 milliliters 3% hypertonic saline bolus over 10 minutes, repeat if needed, while monitoring serum sodium every 2 hours. Diagnosis: severe symptomatic hyponatremia. Likely syndrome of inappropriate antidiuretic hormone, post-pituitary surgery, low serum osmolality, inappropriately concentrated urine, urine osmolarity greater than 100, high urine sodium. Immediate priority. Symptomatic, needs urgent correction to prevent cerebral edema. Bolus hypertonic saline, 100 to 150 milliliters of 3% saline over 10 minutes. Repeat up to 3 times if seizures persist. Continuous infusion at 30 milliliters per hour may be used for controlled correction, but in seizures, bolus is recommended for rapid, life-saving effect. Fluid restriction or urea is appropriate for chronic SI-ADH, not acute symptomatic hyponatremia. Continuous renal replacement therapy with high-sodium dialysate sometimes used if patient has volume overload or renal failure, but not first line in an acute seizure. Tolvaptan is slow, inappropriate in ICU emergencies, contraindicated in acute symptomatic hyponatremia. Correction goals. Initial rise, 4 to 6 millimoles per liter over first 6 hours is usually enough to stop seizures. Do not exceed 8 to 10 millimoles per liter in 24 hours. Risk of osmotic demyelination. Concurrent potassium repletion will also help raise sodium.
Dear doctors, I believe these questions will be useful for you. If you have any feedback, suggestions or comments, please write down in comment section box where I will respond.